Welcome to the deep dive. Today, we're really zeroing in on pediatric cardiovascular dysfunction. This is essential knowledge for all you future nurses out there.
Absolutely.
We've pulled together the critical info from pediatric cardiovascular nursing essentials and, leaning on Wong's nursing care of infants and children for that solid foundation.
Right. And our goal today isn't just listing facts. We want to really unpack these conditions.
Exactly. So you understand the why behind them and you can feel confident applying this stuff in your practice.
We want to get past just memorizing terms. It's about understanding the mechanisms, how these issues actually look in kids, what your role is,
Uh-huh.
the specific actions, the interventions, the treatments, including the meds you'll actually be giving.
Perfect. So we're covering both congenital heart defects, the ones kids are born with, and also acquired heart diseases that might pop up later.
That's the plan.
All right, let's jump in then with congenital heart defects, CHDs. Our source points out these are actually the most common birth anomalies.
They really are.
Yeah.
And a key starting point is just understanding how we categorize them. It basically boils down to how blood flows or doesn't flow correctly.
Yeah.
So you'll hear about acyanotic defects. Think increased blood flow to the lungs, often. Then obstructive defects, where something's literally blocking the flow. Then cyanotic defects, less blood getting to the lungs. And finally, mixed defects, where you've got this complex mixing of oxygenated and deoxygenated blood.
Okay, let's start with those acyanotic ones. You said increased pulmonary blood flow, often left to right shunting.
Exactly. Blood takes the path of least resistance, moving from the higher pressure left side of the heart over to the lower pressure right side. And that extra blood ends up going to the lungs.
So first up is atrial septal defect, ASD. What's the key thing for nurses to grasp about ASD?
Okay, so with ASD, you've got an opening, a hole between the atria, the two top chambers.
Yeah.
Left atrial pressure is usually a bit higher.
Yeah.
So blood flows across that hole into the right atrium, then to the right ventricle, and boom, extra blood pumped to the lungs. The subtle thing here is, even if the baby looks fine initially, that extra flow over time can strain the pulmonary vessels.
And what would we actually see? The source says many are asymptomatic, maybe some fatigue, or a murmur.
Yeah. Often the murmur is pretty soft, a systolic ejection type murmur.
Yeah.
It's that extra volume going through the pulmonic valve causing the sound.
Okay.
So nursing care-wise, if it's small, it might just close on its own. Your job then is careful assessment, listening for that murmur, asking about fatigue, especially with activity. If it needs fixing, maybe with a catheter or surgery, then you're looking at pre- and post-procedure care, watching for any issues afterwards.
Makes sense. Okay, next acyanotic one. Ventricular septal defect, VSD. Sounds similar, but lower down in the heart.
Correct. VSD is an opening between the ventricles, the bottom chambers, and it's actually the most common CHD.
Oh, wow.
Okay, same principle. Higher pressure on the left pushes blood across to the right ventricle, leading again to more blood flow to the lungs. But because ventricle pressures are higher and the difference is greater, VSDs can often have a bigger impact than ASDs.
Right. And the signs might be more obvious. The source mentions a loud murmur, maybe signs of heart failure. What specifically signals heart failure in a kid with VSD?
Yeah, this is critical for nurses.
Yeah.
Early recognition is key. In babies, look for poor feeding. They might just get exhausted trying to eat,
Okay.
not taking in enough formula or breast milk.
Yeah.
Also, tachypnea, fast breathing, even when they're resting.
Oh.
You might see retractions too, the skin pulling in around the ribs or neck.
Yeah.
And diaphoresis sweating, especially when they try to feed. These all scream heart failure.
So treatment for VSD. And how does nursing fit in?
Well, some small ones might close on their own. If it's large, causing those heart failure signs, poor growth, then surgery is usually needed to patch the hole. Nurses are vital here, monitoring for those heart failure signs we just talked about. And if surgery happens, it's all about that pre-op prep and really careful post-op care pain, watching the wound, looking for infection complications.
Got it. All right, moving on to patent ductus arteriosus, PDA. This one's about a vessel that's supposed to close after birth.
Right, exactly. The ductus arteriosus connects the pulmonary artery and aorta in the fetus, letting blood bypass the lungs. It normally closes pretty quickly after birth.
But in PDA, it stays open.
Right, so you've got this connection between the aorta carrying oxygenated blood and the pulmonary artery. Oxygenated blood flows back into the pulmonary circulation. Again, more work for the lungs, more work for the left side of the heart.
And the classic sign is that machinery-like murmur. What gives it that sound? And what else might we find?
It's the continuous flow through that open duct during both systole and diastole. That's the machinery sound. You might also feel bounding pulses.
Bounding pulses. Why?
Well, the left ventricle is pumping harder, a larger stroke volume, trying to compensate for that blood chunking back to the lungs. So you feel stronger pulses peripherally. Treatment varies. Sometimes, especially in preemies, we use medication. Indomethacin is common.
Right. Indomethacin, how does that work again?
Okay, so indomethacin is an NSAID, a non-steroidal anti-inflammatory. Its main job here is blocking prostaglandin production.
Prostaglandins. They keep the ductus open in the fetus.
Precisely. So by blocking them, indomethacin encourages the ductus to constrict and close, especially in preemies who are more sensitive to those prostaglandin levels. Other options are catheter closure or even surgery to tie off the ductus.
And nursing care involves?
Meticulous assessment, checking those pulses, listening carefully to the murmur. If giving indomethacin, watching for side effects like lower urine output or tummy issues, and of course pre- and post-procedure or surgical care.
Okay. Last one in this acyanotic group. Atrioventricular canal defect. Sounds complex.
Oh.
Involves multiple parts.
It does. AV canal defect, sometimes called endocardial cushion defect. It happens when the central part of the heart, formed by the endocardial cushions, doesn't fuse properly during development, so you often end up with a hole connecting both atria and both ventricles right in the middle, plus issues with the mitral and tricuspid valves. Big impact.
Wow.
Leads to increased pulmonary flow and valve problems, and a really important connection for nurses. AV canal defects are strongly associated with Down syndrome.
That's a key point. And surgery is the main fix. What are the nursing considerations, especially knowing about the Down syndrome link?
Yeah, recognizing that higher risk in infants with Down syndrome is crucial right from the start. They might show more significant signs of heart failure because of the amount of shunting. So you're watching closely for fast breathing, poor feeding, failure to thrive. Pre- and post-op care after the repair is critical in managing breathing, fluids, infection risk, and providing really sensitive support to the family, considering any other needs related to Down syndrome.
Okay, good. Let's shift gears to obstructive defects. Here the issue is a blockage, right? Something stopping blood from leaving the heart properly. First is coarctation of the aorta.
Right. Coarctation is a narrowing, like a pinch, in the aorta, usually near where the ductus arteriosus was. The main effect. It blocks blood flow going to the lower body. This creates a difference in pressure and blood supply between the arms and legs.
And that's the classic sign nurses look for, isn't it? Higher blood pressure in the arms than the legs. Stronger pulses up top.
Exactly. Blood pressure is significantly higher in the upper extremities.
Yeah.
You feel those strong, maybe even bounding pulses in the arms, but weak or maybe even absent pulses in the legs. That difference is a huge clue.
Treatment
Can be balloon angioplasty, using a catheter to stretch the narrow part open, or surgery to cut out or bypass the narrowed segment.
nursing focus.
Careful, consistent checks of blood pressures and pulses in all four limbs. That comparison is key. Post-procedure or post-op, you're watching for re-narrowing, high blood pressure, and making sure the lower body is getting good blood flow.
All right. Next, obstructive one, aortic stenosis. What's the issue here?
Aortic stenosis is a narrowing of the aortic valve itself, the door between the left ventricle and the aorta.
So it restricts blood flow out to the body.
Right. The left ventricle has to pump much harder to push blood through that narrow valve. Over time, the muscle can thicken hypertrophy, and cardiac output can drop.
What signs might you see in a child?
Well, you'll likely hear a systolic ejection murmur when you listen. Kids might have exercise intolerance, they get tired or breathless really easily with activity.
Makes sense.
Older kids might even complain of chest pain or feeling dizzy, especially when they exert themselves.
And treatment?
Options include balloon dilation to stretch the valve, or surgical repair, or even replacing the valve. Nursing care means assessing for that murmur, watching for any signs of low cardiac output like fatigue, poor feeding in babies, activity changes, and then the usual pre- and post-procedure or surgical care, monitoring closely.
Okay. Last one in this group, pulmonic stenosis. Similar idea, but on the right side.
Precisely. Pulmonic stenosis is a narrowing of the pulmonic valve between the right ventricle and the pulmonary artery, which takes blood to the lungs, so it blocks flow from the right ventricle into the pulmonary circulation. If it's severe, pressure builds up in the right ventricle, less blood gets to the lungs, and you might even see cyanosis, that bluish tint.
And a murmur, too.
Yep, typically a systolic ejection murmur again. Treatment is often balloon valvuloplasty to open the valve, or surgery. Nursing involves listening for the murmur, assessing for any cyanosis, especially when the child is active, and providing support before and after any intervention.
Okay, now we're heading into the cyanotic defects. These mean reduced blood flow to the lungs, leading to lower oxygen levels and that bluish color, cyanosis. First is tetralogy of Fallot, TOF, a famous complex one with 4 parts.
Yes, TOF is definitely complex. The 4 pieces are 1. A ventricular septal defect, VSD. 2. Pulmonic stenosis, narrowing of the pulmonary valve area. 3. An overriding aorta, where the aorta sits over the VSD, getting blood from both ventricles. And 4. Right ventricular hypertrophy, because that ventricle is working so hard against the stenosis.
So how does that lead to cyanosis?
It's a combination. The pulmonic stenosis limits blood flow to the lungs. The VSD allows deoxygenated blood from the right ventricle to shunt across directly into the overriding aorta, mixing with the oxygenated blood going to the body. Result, lower oxygen levels systemically.
Got it. And the source mentions TIT spells. What are those, and what do nurses do immediately?
TIT spells. Hypercyanotic spells. These are sudden episodes where the cyanosis gets much worse. The child might breathe rapidly and deeply, get very irritable, maybe even lose consciousness.
Scary. What triggers them?
Often things like feeding, crying hard, even having a bowel movement, stressful events. We think it's caused by a spasm in the muscle below the pulmonary valve, suddenly clamping down blood flow to the lungs even more.
And the nursing response?
Crucial. First, calm the baby, then put them in a knee-chest position.
Knee-chest, why?
It increases resistance in the systemic circulation, which can help push more blood towards the pulmonary artery instead of across the VSD. Give oxygen too, though remember the main issue is the shunt, so oxygen alone might not fix it completely. Sometimes meds like morphine are given to relax that muscle spasm.
Okay. Long-term fix is surgery.
Yes, surgical repair, either in stages or all at once. Nursing care involves teaching parents how to handle TIT spells, constantly monitoring oxygen levels, and full pre- and post-op care.
Right. Next cyanotic defect. Tricuspid atresia sounds very serious from the name.
It is severe. Atresia means absent. So the tricuspid valve, the door between the right atrium and right ventricle, just isn't there. This means deoxygenated blood returning from the body can't get into the right ventricle to be pumped to the lungs in the normal way.
So how does the baby survive at all?
Survival depends entirely on other defects being present. You need an ASD or PFO, so blood can get from the right atrium to the left atrium. And critically, you need a PDA, a patent ductus arteriosus, so blood from the aorta can get back to the pulmonary artery and reach the lungs.
Wow, so that PDA is absolutely life-saving. And the initial treatment listed is prostaglandin E1. Why is it so vital here?
Prostaglandin E1 keeps that PVA open. In tricuspid atresia, the PDA might be the only way blood can reach the lungs to get oxygenated. Without it, the baby can't survive.
So starting that infusion is urgent.
Absolutely urgent. Long-term treatment involves stage surgeries, like the Glenn-Fontaine procedures. Nursing in the newborn period is all about that prostaglandin E1 infusion, starting it, monitoring its effects, watching for side effects, plus all the complex pre- and post-op care for multiple surgeries.
Okay, now for the mixed defects where oxygenated and deoxygenated blood get mixed up, first is transposition of the great arteries, TGA.
Right. Transposition means switched. The aorta comes off the right ventricle, sending deoxygenated blood to the body. The pulmonary artery comes off the left ventricle, sending oxygenated blood back to the lungs.
Two separate circuits that don't connect properly.
Exactly. Oxygenated blood just goes round and round the lungs. Deoxygenated blood goes round and round the body. A critical point for nurses. These babies are profoundly cyanotic, and giving them extra oxygen doesn't help.
Why not?
Because the lungs are working fine, they're oxygenating the blood. The problem is that oxygenated blood isn't getting out to the body, it's trapped in the lung circuit.
That's a crucial distinction, and again, prostaglandin E1 is listed first.
Yes, same reasons as before, but slightly different effect. Keeping the PDA open allows some mixing between the two circuits. Some oxygenated blood from the pulmonary artery can sneak across the PDA into the aorta, giving the body at least a little oxygen until surgery.
And the surgery?
The definitive fix is the arterial switch operation, ideally done very early, where they basically cut the arteries off and switch them back to the correct ventricles. Nursing means recognizing that cyanosis that doesn't respond to O2, getting that prostaglandin E1 started and monitored, and prepping the baby and family for major surgery.
Last CHD on our list, hypoplastic left heart syndrome, HLHS, hypoplastic meaning underdeveloped.
Exactly. A very severe complex defect where the entire left side of the heart, left ventricle, mitral valve, aortic valve, ascending aorta is significantly underdeveloped. It's just too small to pump blood effectively to the body.
Signs are cyanosis and heart failure, and prostaglandin E1 is essential again.
Absolutely essential. In HLHS, the right ventricle has to do all the work, pumping blood to both the lungs and the body. It pumps blood to the body via the PDA. So keeping that ductus open with prostaglandin E1 is critical for systemic blood flow.
Treatment sounds intense.
It is. Usually a series of three-stage surgeries, the Norwood, Glenn, and Fontan, designed to make the right ventricle the main systemic pump. Or sometimes heart transplantation is considered. Nursing care for HLHS is incredibly demanding. Recognizing it early, managing the prostaglandin, intensive care in the CICU, and huge amounts of support for the family facing a really tough road.
Whew. That's a lot on congenital defects. Let's switch now to general management that applies across many of these. Medications first. We've hit prostaglandin E1 hard.
Yeah,
What else?
right. Diuretics like furosemide are very common, especially when there's heart failure. All that extra lung blood flow or poor pumping leads to fluid overload. Diuretics help get rid of excess fluid, reduce the heart's workload.
Nursing points for diuretics.
Monitor urine output closely, watch for dehydration signs, and definitely keep an eye on electrolytes, especially potassium. Furosemide can make potassium levels drop. Then there are ACE inhibitors, like captopril.
How do they help?
They block an enzyme, leading to vasodilation, widening blood vessels. This lowers blood pressure and reduces afterload.
Afterload. The resistance the heart pumps against.
Exactly. So ACE inhibitors make it easier for the heart to pump blood forward. Main nursing watch-out is monitoring blood pressure for hypotension, low blood pressure.
And then there's digoxin, a tricky one.
Very tricky. Digoxin helps the heart contract more forcefully and can slow the heart rate. Good for improving output, managing some arrhythmias, but it has a narrow therapeutic range.
Meaning the line between helpful and harmful is thin.
Very thin. So nursing responsibilities are huge. Always check the apical pulse for a full minute before giving it. If the rate's too low based on the doctor's parameters, you hold the dose and notify them.
And watch for toxicity.
Absolutely. Signs like bradycardia, slow heart rate, nausea, vomiting, poor feeding, feeling sluggish, rhythm changes. Need to monitor drug levels in the blood too.
Okay. Nutrition support is also highlighted. Makes sense these kids would need extra help.
Definitely. They often burn more calories just because their heart is working so hard.
Yeah.
But at the same time, they get tired easily when feeding because they might be short of breath.
So the solution.
Often, high-calorie formulas, more bang for the buck, calorie-wise and less volume. We also suggest frequent, smaller feeds so they don't get too worn out. And sometimes, if they just can't take enough by mouth, they might need NG or OG tube feedings to make sure they get enough nutrition to grow. Monitoring weight gain is absolutely critical.
And finally, general surgical care points, pre-op and post-op.
Pre-op, the focus is getting the child as stable as possible. Good oxygenation, stable vitals, baseline assessments, heart, lungs, neuro. Plus, lots of education and support for the child and family to reduce anxiety. Post-op, it's intensive monitoring. Heart rate, rhythm, BP, oxygen, sats continuously. Watching for complications like arrhythmias, bleeding, infection. Pain management is key for comfort and recovery. And fluid balance is huge. They can easily get overloaded or dehydrated after big heart surgeries. So strict intake and output monitoring.
Okay, great overview. Let's make one last shift to acquired cardiovascular disorders, conditions that develop after birth. First up, heart failure. We mentioned it with CHDs, but it can happen on its own.
That's right. Heart failure is basically when the heart just can't pump enough blood to meet the body's needs.
Yeah.
While CHDs are a common cause, things like myocarditis, inflammation of the heart muscle, or rheumatic fever can also lead to it.
Signs and symptoms, similar to what we discussed with VSD.
Pretty similar, yes. Tachycardia, fast heart rate, hepatomegaly, enlarged liver, fatigue, poor feeding in babies, maybe edema. In kids, edema might show up more as puffiness around the eyes or belly swelling, not so much the ankle swelling adults get.
Treatment focuses on
Improving how the heart pumps, getting rid of extra fluid, diuretics again, reducing the workload with rest and meds like ACE inhibitors or sometimes digoxin. Nursing care involves spotting those signs early, giving meds accurately, watching fluid balance and electrolytes, and keeping things calm to help the child rest.
Okay. Next, rheumatic fever. This one follows an infection.
Yes, specifically, it's a delayed inflammatory reaction after a group A strep infection like strep throat. It's an autoimmune thing. The body attacks its own tissues, especially the heart, joints. Absolutely key. Not every strep infection leads to it, but prompt antibiotics for strep are crucial. Symptoms show up weeks later. Polyarthritis, sore, swollen joints, carditis, heart inflammation, the most serious part, can damage valves long-term. Chorea, jerky movements, a specific rash called erythema marginatum, maybe little bumps under the skin.
Treatment involves
Penicillin to kill any leftover strep. NSAIDs for the inflammation and pain. If the heart's involved, maybe steroids. And critically, long-term penicillin prophylaxis afterwards to prevent more strep infections and future rheumatic fever episodes. Nursing means recognizing the varied signs, making sure they take all their antibiotics, including the long-term ones, managing pain, and providing support.
Got it. Then there's Kawasaki disease. Sounds different.
It is. Kawasaki is an acute vasculitis inflammation of blood vessels all over the body. We don't know the exact cause. Mostly affects young kids. It has phases: acute, subacute, convalescent.
What are the telltale signs in that acute phase?
The big one is prolonged high fever over 5 days that doesn't respond well to Tylenol or ibuprofen. Plus, you need several other signs: red eyes, no pus, red cracked lips, strawberry tongue, a body rash, swelling or redness of hands and feet, and swollen neck, lymph nodes.
Wait,
2 main things: intravenous immunoglobulin, IVIG, and high-dose aspirin.
high-dose aspirin in kids, isn't that usually avoided because of Ray's syndrome?
That's a really important point. Normally, yes, but in acute Kawasaki, the high dose is used for its powerful anti-inflammatory effect, specifically to reduce inflammation of the coronary arteries and prevent aneurysms, bulges in the artery wall. That's the major serious complication we worry about.
Okay, so it's a specific indication.
Exactly. Once the fever and inflammation are down, the aspirin dose is lowered to an antiplatelet level to prevent clots, especially if there's any artery damage. Nursing involves monitoring that fever and other signs, giving the IVIG and aspirin correctly, watching closely for any heart issues, and supportive care.
Okay, last acquired condition, infective endocarditis.
Infective endocarditis, or IE. It's an infection of the heart's inner lining, the endocardium, often involving the valves.
Who's most at risk?
Kids with existing heart problems, like unrepaired CHDs or prosthetic valves. These create rough spots or turbulent flow where bacteria or fungi can latch on and grow.
Signs and symptoms, can they be subtle?
They can be. Things like a persistent fever, maybe a new heart murmur or a change in an old one, feeling tired, night sweats, weight loss. Sometimes specific signs like tiny hemorrhages under the nails, splinter hemorrhages, tender spots on finger toes, Osler's nodes, or painless spots on palm soles, Janeway lesions.
Treatment sounds serious.
It requires a long course, usually 4 to 6 weeks, of IV antibiotics, typically through a central line like a PICC. Nursing care is about recognizing who's at risk, spotting the symptoms, giving those long-term IV antibiotics correctly, managing the central line carefully, and lots of education for the family about finishing the whole course and maybe needing preventative antibiotics before dental work later on.
We have covered so much ground today, from congenital defects to acquired conditions. To wrap things up, what are the big overarching nursing considerations we need to remember?
Well, a few things really stand out. First, that constant, vigilant monitoring of vital signs, heart rate, rhythm, breathing, BP, O2 sats, is non-negotiable.
Okay.
Second, remember these kids often have higher energy needs, but tire easily. So clustering your care, doing several things at once when you're in the room, can really help conserve their energy, minimize disturbances.
Good point.
And third, never underestimate the power of emotional support. For the child, sure, but also hugely for the family. A cardiac diagnosis is terrifying. They need clear communication, reassurance, and support.
Absolutely. And that leads right into family education. What are the must-cover topics?
Education is key. You need to explain medications, thoroughly dose, side effects, how to give them. Any activity limits need to be clear. Critically important is teaching parents what signs mean things are getting worse and when to call the doctor or go to the ER immediately.
Empowering them to be partners in care.
Exactly. And finally, stressing how vital it is to keep those follow-up cardiology appointments. Ongoing monitoring is essential. Knowledge and participation really do lead to better outcomes.
This has been incredibly valuable, really understanding the why behind the what in pediatric cardiac nursing.
Absolutely. Connecting that pathophysiology
Yeah.
to what you see at the bedside and knowing why you're doing the interventions you're doing, that's the goal.
So a final thought for all you nursing students listening. Given this huge range of conditions and how fast treatments evolve, how will you commit to being a lifelong learner and a strong advocate for these kids and their families? We really encourage you to dig deeper into any specific conditions that caught your interest today. Thanks for joining us for this deep dive.